friend and very senior cardiologist from Delhi, and he will be talking about pharmacoinvasive treatment of ST elevation microinfarction. Dr. Subhash Chandra requested me to put him in the afternoon session. But in the meantime, I will do some presentation, and our friend Dr. Pathak will do some presentation in this. So we'll finish this scientific symposium on coronary disease within half an hour. After that, we'll have a symposium on manual heart disease, and our great friend Dr. K.T. Kapoor, one of the echocardiographer and clinical cardiologist from Delhi and Noida, working with us for almost for the last 26, 25, 24 years for me. And he will be talking about diagnosis of valvular heart disease by echo Dr. Kapoor. Then Dr. Manisha Chakravarti will talk about interventions in renal heart disease. Our great friend Dr. Jyoti Muthu is here. He was just here, I think he must be out. Okay, he's here. He's a very important cardiac surgeon. And when I asked him how he operates small children, he said when I was doing surgery, somebody noticed that he can operate very small incisions and stitches. So they advised him to go for a congenital heart surgery, and one of the important cardiac surgeon with very good success rate and getting a lot of patients internationally. So he will be talking about recent advances in trachology of fellow, which is a very important subject and one of the most common congenital heart disease surgery.
It's wonderful to be here amongst you for this hybrid course. I'm the opening batsman, and I hope and trust the hall will fill up, but this is a hybrid course, so as Professor Gupta said, we are all learning. What I've been given is pharmacoinvasive therapy, and I think that's quite an important subject because in India, as in even developed world, not every patient with acute myocardial infarction reaches a PCI capable hospital. This is even more so in India, but it is true even in the developed world. And then what to do with these patients? Does every patient then need to be transferred for a PCI because it is superior, or should we thrombolize the patient? If we thrombolize the patient, should we end there? These are very important questions because acute myocardial infarction remains the most important cardiac emergency that we face, both in our part of the world and in possibly in Europe also, this being an Indo-European course. So just to put it in perspective, a 45-year-old woman, diabetic, presenting to a non-invasive center with chest pain of 1 hour duration with 4 mm anterior ST elevation, currently having her periods. That is just there to emphasize that periods are not a contraindication with thrombolysis. And she is stable with no evidence of LVF. She is about 2 to 3 hours away from an invasive center where she could have angioplasty. So for this patient, what is the best treatment? Should this patient be transferred for primary PCI, given that we know that primary PCI is superior to thrombolysis if done in a timely fashion? Or should you give the patient thrombolysis and only transfer if the patient is crashing, in shock or LVF? Or you give thrombolysis and transfer if the ST segment does not settle? Or you give thrombolysis and transfer even if the patient is settled and therefore you plan to do a routine angiogram. So we'll come to the answers later, but basically the pharmacoinvasive approach could be characterized as lyse the patient today and stent tomorrow, because the patient is coming at a time when or to a place where he is not being offered an immediate primary angioplasty, or he is not accepting it, he doesn't understand what is happening. So time being muscle, we need to protect this patient, and so the patient should be thrombolized. That will give at least some benefit. And then even if the patient is settled by this means, even if he shows clinical evidence of reperfusion, then we should transfer the patient to a PCI capable center by a good, safe ambulance service, and within 3 to 24 hours we should do a routine angiogram with the intent to do primary angioplasty if there were significant culprit lesions in the patient. So that is what is pharmacoinvasive therapy, lies today and stent tomorrow, and along with that you have to give all the medicines including dual antiplatelet, since you are giving very intensive thrombolytic therapy, then clopidogrel might be chosen, although ticagrelor could also be used in these patients, and the other therapies like statin, beta blockers, etc. to be given. So, of course, we know that primary PCI, if done in a timely fashion, scores over fibrinolysis. So when the patient comes to me in my hospital, which is a tertiary hospital with 24/7 cover for primary angioplasty, we would first offer the patient a primary angioplasty because it is superior in multiple trials over fibrinolysis. Fibrinolysis with streptokinase will give you reperfusion in about 50% of patients. Even with the second or third generation lytic agents, you might be able to succeed with 60 to 80% of patients. So primary PCI is superior, especially in high-risk cases, shock, large infarct or delayed presentation, but it is not widely available. There is time delay and it is expensive. Majority of STEMI patients still do not get primary PCI in India, hence thrombolysis remains our default strategy. Thrombolysis might work well in uncomplicated cases which present within 3 hours, but then the success is not assured, only 50% with streptokinase. Hence, one should be prepared for a rescue PCI in patients with failed thrombolysis. It's not that you do fire and forget that you've done thrombolysis and that's the end of it. And even in patients who are improving, they are often left with critical residual lesions. So a strategy of routine coronary angiography should be done expeditiously, which is the pharmacoinvasive strategy. And our guidelines different from the West. So we can look at the revascularization guidelines, and I'm just showing the European guidelines, which are quite well known to this audience. And basically, if the patient can be offered a primary angioplasty within 2 hours of first contact, so either the patient has come to a hospital with 24/7 primary PCI cover, or the patient can be quickly shifted, then the patient should be offered a primary PCI. For all other patients, it is considered that they should be sent for fibrinolysis with the best available agent. So consider drugs like tenecteplase and alteplase in reference to streptokinase. And then these patients, even if they are settled, even if they are showing ST resolution, they should be transferred for routine angiography and PCI. So that is in summary what it is. And but this entails a lot of time pressure, and often we are not able to meet these time goals. These are the important time targets. You should do an ECG within 10 minutes. Maximum delay from first medical contact to wire crossing, that is sort of door to needle time, door to balloon time would be 120 minutes. And so variously from 60 to 120 minutes, you have to complete your procedure. And data suggests that even in developed countries, 1/3 to 1/4 of the patients undergoing primary PCI are not getting treated within these timelines, leading to higher mortality. The situation in our country is obviously worse, and treatment delayed is actually treatment denied. We know that there is a very tight correlation between delay in treatment and increase in mortality, and it is treatment denied because you do have an alternative which is reasonably good in the form of thrombolysis. And in order to get the better treatment, you are giving delayed treatment, which often goes to the detriment of the patient. So, therefore, what to do after thrombolysis? You need to identify failed reperfusion and transfer such patients for immediate rescue PCI if they have shock or recurrent VT, or if they fail to show ST segment resolution. But even if patient is settled, then you should consider routine early PCI. So, as opposed to thrombolysis alone, multiple trials, and these are now somewhat dated, have shown that doing routine early angiography will be beneficial. So many trials are listed here. So pharmacoinvasive strategy is better than thrombolysis alone. And the STREAM trial, which is also now somewhat dated, has shown that if you cannot do a primary PTCA within 60 minutes of the patient arriving, then it may be beneficial to go for thrombolysis, be it with half dose or with full dose, and then go on to early angiography, which is the pharmacoinvasive strategy. So in the developed world and in the developing world, it's not just a strategy of deprivation. We have data from the Indian STEP AMI study from Tamil Nadu with Dr. Ajit Mulasari pioneering it. And this was observational multi-center prospective study, 200 patients followed for up to 2 years. 45 patients chose not to go for immediate PCI. So this is not a randomized study really. And 150 patients went for primary PCI. The outcome was better in the primary PCI group, no doubt, but the differences were small and they reduced from 30 days to 2 years. So a pharmacoinvasive strategy results in outcomes that were comparable with primary PCI at 2 years, suggesting that it might be a viable option in India. So this is the actual data. So no doubt the odds ratio is not so great for pharmacoinvasive therapy, 2.87, but the p-value is not significant. So not significant difference, and then the odds ratio for the difference in outcome has reduced at 2 years, and also for death and for the combined endpoint. So at least in patients who are not accepting a primary PCI, even if they reach a PCI capable center, we should still be offering them thrombolysis. Much the same thing has been looked in a more contemporary trial in again from France. This I think is from China actually. 344 patients and expected PCI delay, and there it was found that if you give half dose lytic therapy to them followed by a pharmacoinvasive therapy, then you will achieve similar TINI flow rate, similar TINI myocardial blush, similar ST segment resolution, similar size of infarct on MRI, and similar clinical outcomes by and large, death, reinfarction, heart failure, stroke, etc. There's only some increase in minor non-intracranial hemorrhage. So give these patients who are not feasible for immediate primary PCI half dose lytic, then 3 to 24 hours later, you can carry it forward with a routine angiography followed by plastic. So therefore, the question which we had posed, and I think the answer should be clear, to my mind it is, this patient who will not be able to get primary PTCA within the window period should be given, and she's a young patient, should be given full dose lytic, and she should be transferred to a PCI center for PCI within 3 to 24 hours. I would choose a third generation lytic rather than streptokinase.
Of course, primary PTCA is always better if it can be done in a window time. So we'll have actually the session of coronary artery disease. We will have some discussion after one more talk by Dr. Tanuj Bhatia, who will be covering Amit Munjal. But this topic is different, it's stable coronary artery disease. There will be a lot of discussion about stable CAD. That means you have stable CAD, then you should not do angiography or angioplasty. And there have been so many trials which has got confusion in the mind of physicians and interventional cardiologists both, and also the public. A lot of media have shown that sometimes do unnecessary angioplasty, the patient is stable, why to do let the plaque continue, let the patient continue controlled angina by anti-angina drugs. So we will just tell the highlights about the myth about the stable coronary artery disease, especially Catholic population. Tanuj, please come and introduce yourself.
Everything really stable, or are all stable coronary artery disease patients of the same intensity. So the next few minutes would be toward dispelling the myth of this stable coronary artery disease, especially in high risk population like diabetics. And as we know, diabetes and atherosclerosis, it's an interplay between various factors, not directly linked to each other in 1:1 proportion. There is diabetic nephropathy happening, there is heart failure happening, and diabetes and CAD, it is not just a risk factor. And if we see according to the international classification of the diabetic patients at risk for coronary events, there is nothing called as a low risk. The patients fall either into very high risk or high risk in majority of the cases. And those who are very young, less than 35 years of type 1 diabetes and less than 50 years of type 2 diabetes with a diabetic duration of 10 years without any risk factors, only those patients are in moderate risk. And in the Indian context, more peculiarly, there is nothing called as moderate risk also. 60% patients fall into the category of very high risk and 40% patients fall into the category of high risk. So it is extremely important to appreciate this difference, especially new onset diabetes in India as compared to our other ethnicity, maybe UK, people from UK. The patients from India, they are diagnosed around a decade earlier as compared to other areas. They have less generalized obesity and thinner limbs, but they have more central adiposity, they have more insulin resistance, the waist-hip ratio is more, the fat percent is more, and despite the fact that the BMI is around 4 to 6 kg per meter square less and the mid-arm circumference is 20% less. And this has been termed as a mnemonic that is first aid, the combination of adiposity, insulin resistance, and dysglycemia that leads to failing myocardium, ischemic heart disease, renal or retinal dysfunction, and autonomic dysfunction in form of systolic BP changes and tachycardia and orthostasis. So we have to look at it as a continuum, we have to look at it as in a totality. And if now coming to the exact point, why are we calling stable? If you carefully risk, this is the best data as of now according to the REACH registry that tells us that patients, those who have coronary artery disease with stable angina, have a 4-year incidence of MACE of 16%. Now look downwards. CAD with type 2 diabetes mellitus, the 4-year incidence is the same, 16%. So we should actually understand whether the patient has stable angina or whether the patient has diabetes. The 4-year incidence of MACE is almost similar. And compare it with CAD with previous cardiovascular event, that means CAD with a past history of ACS, the rates are almost similar to the tune of 18.3%. So where is the difference of stable versus unstable? Despite the fact that the patient has stable angina, the rates of MACE are almost similar, and similarly high rates are seen in patients those who have CKD with an eGFR of less than 30 ml per minute per 1.73 meter square body surface area, that is 18.88%, and in fact slightly higher. So we have to understand that we are dealing with a heterogeneous population, and not every stable CAD is stable CAD, and it should be more thoughtfully, more logically be termed as chronic CAD instead, because we see it over the long term, we see a lot of recurrences, and we see despite the newer therapies coming in, we are seeing events happening in stable ischemic heart disease almost similar rates as with ACS. Complications and statistics leads us to think that we have to give primary prevention to all patients, but also focus on secondary prevention. And we are witnessing really fortunate advances in this era. We have an array of anti-thrombotic strategies, from aspirin alone to clopidogrel alone on the basis of Capri trial, combination of aspirin plus ticagrelor in Themis trial, a combination of aspirin plus rivaroxaban in Compass trial. We have seen novel lipid modifying therapies with the availability of PCSK9 inhibitors.
I would compliment Dr. Tanuj on the excellent talk. Of course, just to sound a note of caution when we say that we are moving from significant lesion to vulnerable lesion and then on to vulnerable patient, then the whole approach although things like Prospect AMI did show that if you have a vulnerable plaque and it is non-stenotic, then we should stent it. But that is something which is not yet class 1, just a vulnerable plaque, because so many plaques will be vulnerable whether you do it by the virtual histology or you do it now by OCT or CT angiography. There's lots that can be done even in terms of risk factor control, then reaching the LDL targets, reaching the glycemic targets, etc. So I think the point is very well taken that we have to consider the vulnerable patient. The vulnerable patient may have some vulnerable plaques which, when they reach the level of an ACS, certainly need stenting. In the patient who has not reached that level, the courage and ischemia trial, we are still quite at sea, because in the ischemia trial there were some patients with reversible ischemia also, and even there the benefit was not shown.
Opportunity to speak on this topic of this valvular assessment by echocardiography. Now, I mean, it is just the same that 2D echocardiography and color Doppler, they are the most cost effective, they are easily available as well as portable methods for the complete evaluation of cardiac valvular lesions. And you can see this mitral stenosis here. This is a moderate MS, and you can see on 2D and you can see it on color the turbulence as the blood flows from the left atrium to the left ventricle. And this is the mitral valve orifice area, which you can do by 2D planimetry as well as by 3D planimetry. So generally speaking, the 3D planimetry is more accurate because you know exactly where to take that area from. Because this valve domes, and therefore you have to take it at the tip, and right at the tip, and you have to be parallel to the plane of the mitral annulus. So therefore the 3D is more accurate, and generally it gives a low reading as compared to 2D orifice area. So if you have a mild mitral stenosis, the orifice area is between 1.5 to 2.2 centimeters square. If it is a moderate mitral stenosis, it is 1 to 1.5 centimeters square. And if it is a severe MS, it is less than 1 centimeter square. Now there is another method to calculate the mitral valve area by the continuity equation. So what you do is you take the LVOT diameter in the parasternal long axis view, and 0.785 d squared gives you the cross-sectional area, which you multiply by the LVOT VTI, and that gives you the stroke volume. The stroke volume divided by the VTI across the mitral valve itself. That gives you the mitral valve area in centimeters squared, and this is useful especially in those patients who do not have significant mitral regurgitation. So, and there is yet another method by Doppler that is called the pressure half time. And that is the time taken for the peak pressure gradient to drop by 1/2. The velocity of the pressure half time is given as V1 by square root of 2 or 0.7 into V max. And the mitral valve area in centimeters squared is 220 divided by the pressure half time. And in this particular case, 220 by 171 gives you 1.28 centimeters squared. So going purely by the pressure half time, a mild mitral stenosis is a pressure half time between 100 to 150. A moderate mitral stenosis 150 to 220 centimeters squared, and a severe mitral stenosis is more than 220 centimeters squared. Then you have a PISA method by which you can take the mitral orifice area, but actually we don't use it much. It's a little complicated, requires some expertise to do it, and takes time. So in the interest of saving time, generally we do not prefer to use this method, so I'll not speak in much detail about it. Then of course you take the pressure gradients,
it's always better to take the mean pressure gradient, and this can be measured by tracing the dense outline of the mitral diastolic inflow that is shown over here, and the mean pressure gradient is automatically calculated. The mean pressure gradient, if it is less than 5 is mild mitral stenosis, 5 to 10 is moderate MS, and a severe MS is the mean pressure gradient less than 10. But you must understand that these gradients, they go on changing. And for the same orifice area, there could be these multiple gradients. So therefore, you have to see what are the hemodynamics. If the cardiac output is very low, then the mean pressure gradients will be very low, although the mitral stenosis is tight. And similarly, these mean pressure gradients will be very high if the patient has a high cardiac output state. Now you have to also measure the PA pressures. If there is a significant pulmonary artery hypertension, then the patient goes into pulmonary hypertension, which is both due to a passive pulmonary hypertension and as well as there is a vasoconstriction of the pulmonary arterioles. That is the reactive type of this pulmonary hypertension. So if you have a PA systolic pressure of more than 70, that is taken as severe pulmonary stenosis. Now this is mitral regurgitation. You can see that the inflows, this flow from the LA to the LV, these blue colored signals in systole, these are the flow signals of mitral regurgitation. Now you can compute the severity of this by these multiple methods, and the most common method that we have been using over the last several decades is actually to planimeter this mitral valve area in whichever view we get the best and compare it with the left atrial area. So if you have the regurgitant jet area of the MR jet, and if you compare it with the LA area, if it is more than 40%, then it is considered a severe. But nowadays we are using other methods to actually compute the severity of mitral regurgitation, and that is the vena contracta. Now this vena contracta is the narrowest portion of the jet as it goes from the LV to the LA, and just on the LA side of the mitral orifice. So if you take the width of this vena contracta, if it is more than 7 millimeters, it is severe MR, and less than 3 millimeters is mild MR. Similarly, you could use the PISA method. I will not be going into the depths of the PISA technique, but suffice to say that we take the flow acceleration that is on this proximal side of the mitral valve. Now this actually is the transesophageal echo, so the LV is down and the LA is above. So therefore you are seeing that flow acceleration, and you are taking the radius of the flow acceleration 0.97 centimeters, and we are taking the mitral regurgitation Doppler spectral trace that is above the baseline, as you can see, and therefore you can use this formula of 6.28 r squared into the first aliasing of this PISA and divided by the peak velocity of the MR jet. That gives you the effective regurgitant orifice area, and if you multiply the effective regurgitant orifice area by the VTI, that gives you the regurgitant volume. Now there is another method you can use is to see the flow in the pulmonary veins. Now it may not be possible all the time to see this pulmonary venous flow on transthoracic echo, and may require transesophageal echo. But whatever the method used, if you can see the flows. Now what happens in the case of this severe MR is that you lose the antegrade systolic flow, that is S wave, and that is replaced by the systolic regurgitant flow, which is labeled here as SRF. So if you get a systolic reversal of flow in the pulmonary veins, it is consistent with severe mitral regurgitation. Now you come to aortic valve, and you take the aortic stenosis if we begin with. Generally, the aortic stenosis jets is eccentric, and the acoustic windows also may not be very good. So you have to use these multiple windows, starting from the apical plane, and then the right parasternal plane, the suprasternal plane, the left upper parasternal plane, and the subcostal plane. And you'll get the Doppler spectral and take the best Doppler spectral tracing and calculate out the mean gradients as well as the VTI and the valve area, which you get by what is called the continuity equation. The aortic valve area, as shown diagrammatically here, is the LVOT cross-sectional area multiplied by the LVOT VTI divided by the aortic valve VTI. So that gives you these, and the ratios of the VTIs is actually the ratios of the peak velocities. So you can shorten this formula to include just the peak velocity of the LVOT divided by the peak velocity across the aortic valve. And you can also take what is called the velocity ratio, that is this velocity in the LVOT divided by the velocity across the aortic valve. That is called this velocity ratio, and accordingly you can get the valve areas. I'll have to take a little more time, please. So you get the aortic valve area by 3D echo also. You can get a cross-sectional view, which is called NFAS view. And you can get the aortic valve. This is by the transesophageal 3D. So you can directly planimeter it on 3D, which is little difficult to do on 2D. And thereby you can get the mean pressure gradients, this velocity ratio, aortic valve, peak velocity, aortic valve area, all can be done. And you can get the aortic valve area. If it is less than 1, it is severe aortic stenosis. A peak velocity of more than 4 meters per second, a velocity ratio of less than 0.25, a mean pressure gradient of more than 60, and an index aortic valve area of less than 0.6 centimeters square per meter square is actually severe AS. Now we can also do actually this is not playing now, it was playing very well actually, I have checked it many times. Anyway, yeah. So you are getting the AR jet, you can see over here. So we are now looking at aortic regurgitation. And what we used to do earlier was to look at the jet width that we have been doing for last 20-30 years. What we have been doing is to look at the jet width at the origin and compare it with the LVOT width. But now we got other methods, that is the vena contracta, this PISA, and we can also use the volumetric method by this conventional Doppler and regurgitant fractions. So you can see over here the aortic jet width or the aortic height, and this is how we actually calculate the jet width, which is also called the jet height, and compare the width as compared to the LVOT. And if it is less than 25%, it is grade 1, 25 to 46 is mild or so, that is actually mild to moderate, to 25 to 46%, 47% to 60% grade 3, and grade 4 is more than 60%. So this is the vena contracta, which is the narrowest portion of the jet as it escapes from the across the aortic valve into the LVOT. So you take the width of the aortic regurgitation. Mild is less than 3 millimeters, a moderate is 3 to 6 millimeters, severe is more than 6 millimeters vena contracta. And similarly, then we can use the Doppler methodology to actually calculate the regurgitant volumes. Just taking the basic principle that the flow across the regurgitant valve is called the total stroke volume, and the flow across the normal valve is called the forward stroke volume. So the regurgitant volume is the total stroke volume minus the forward stroke volume, and that divided by the total stroke volume gives you regurgitant fraction. A regurgitant fraction of more than 50% is considered severe. A regurgitant fraction of more than a regurgitant volume of more than 60 ml is considered severe. And then you can take the backflow in the suprasternal notch, and this pan-diastolic backflow, if you get, that indicates severe AR. You can also use the pressure half time. A pressure half time of the AR jet of more than 400 milliseconds indicates mild AR. A pressure half time of less than 200 milliseconds indicates severe AR. Now you can also have this TR jet, and you want to actually measure the severity of tricuspid regurgitation. So you can use the jet area method. If it is more than 10 centimeters square, it is severe TR. Then you can use you can also use the vena contracta, you can use the PISA, and you can get a good quantitative assessment of TR jet. Now the TS actually is, you take the mean pressure gradient across the tricuspid valve. If it is more than 5 millimeters of mercury, then this is severe TS. And if you take the VTI across the tricuspid valve, if it is more than 60 centimeters, it is severe TS. A pressure half time of equal to or more than 190 milliseconds is severe TS, and by continuity equation valve area of less than 1 centimeter square is also severe TS. Now you come to PS. Actually for PS, this is simply that if you get a peak velocity less than 3 is mild, 3 to 4 meters per second is moderate, and more than severe is 4 meters per second. Then you have the peak gradient of less than 36 to 64 and more than 64, and a valve area if you are able to calculate by continuity of less than 1, then that is also severe PS. Now you come to PR, you can see that a pressure half time is one of the good methods. Shorter the pressure half time, more severe the PR. A PR, if this pressure half time is less than 100 milliseconds, it indicates a severe PR. And if you have a jet larger than 50% of the pulmonic valve annulus, that is also severe PR. And if the jet width is more than 65% of the RV outflow tract, is also severe PR. So this is how we actually estimate the severity of the PR jet. So we have covered all the 4 cardiac valves. Thank you very much for your attention, and sorry for exceeding my time.
Gupta and this Indo-American European Conclave to bring this important topic for discussion, timing of intervention in congenital heart disease. So about congenital heart disease, this statement is very true, that the importance of time, like the words and the moments, after we gone, we cannot get them forever. So for congenital heart disease also, the time is very important. So if we think that the means like we had in our, when we were also in the learning phase, that a whole like a PhD, we wait for 10 years till this natural history is closed on its own, is actually not true. And many of these heart disease patients turn to Eisenmenger syndrome inoperable, at the age of as early as 1 year of age. So the natural history of all the congenital heart disease is actually dismal compared to the surgical outcomes and the interventions, which is actually very excellent, and in best centers the mortality rates are less than 1%. The secondary pulmonary vascular disease and the myocardial dysfunction that we get to see in our adult congenital group of patients is actually because we have neglected them and not operated them on proper time. So if we divide our congenital heart disease, I will keep it very simple that it can be a blue baby or a pink baby, like acyanotic versus the cyanotic. The acyanotic, mainly we have three categories of patients: the left to right shunts, the obstructive lesions, and the cardiomyopathies. The cyanotic heart disease are divided into two. They can have increased pulmonary blood flow or decreased pulmonary blood flow. So most common heart disease, as we know, is the ventricular septal defect. Very often all of us have seen there will be loud pansystolic murmur or a injection systolic murmur, loud pulmonary P2 sound, and cardiomegaly, which will tell us that it is a VSD or a PDA. The blue babies most commonly will be a tetralogy of Fallot, though it can be a transposition or many other possibilities. So I come to the simplest, the ASD, atrial septal defect, which can be of ostium primum, which is in the lower part of the septum, the sinus venosus within the sinus with the SVC or the IVC, and the middle defects of the fossa ovalis. So for treatment, my topic is on the timing of intervention. So this treatment of ASDs all ASDs can be closed by surgery. However, fossa ovalis ASDs be closed by device also with the suitable rings. And this is a picture of a device which is deployed in selective cases. So time will be around 4 years, not like 20-30 years, because the ASDs also after the first decade, they can develop pulmonary hypertension, and the right ventricular volume overload will lead to gradually right ventricular failure. So the ideal time internationally accepted is around 3 to 4 years. And if 5% of them, 5 to 10% can have pulmonary hypertension in ASDs also in the early age, and they need early surgery. The ventricular septal defects. When the VSDs are large, that means the VSD is such that the lung pressures, PA pressures are more than 2/3 of the systemic pressure. So that is considered as a large VSD. We do not go by the size these days. And the PA pressure, and there is cardiomegaly, the left ventricular volume, the size is enlarged, then these are the VSDs which need a closure. So VSDs mostly are closed by surgery, but then there are selective VSDs which can be closed by devices also. The time, if it is a large VSD, the CHF is not controlled, we can close them as early as 2 months. The large VSD is controlled CHF by 6 months of age, and if it's a moderate VSD, we can take time up to 2 years. So the two indications will be LV volume overload. As we can see, Dr. Kapoor has described that echo is so important. So here lies the importance of doing a good echocardiography in a VSD, where we will check the LV size by the M modes, and more than 2 Z scores. Z scores are the standard deviation. So more than 2 Z scores will indicate that LV is dilated, and the PA pressures are high, more than at least 50-60% will indicate that this VSD needs to be closed. So muscular VSDs we can close by a device. This is a class 2A indication. Professor Anita Saxena in 2019 has published an article after a consensus, where I was also fortunate to be a member of that, about the timing of interventions in congenital heart disease, which is a very precise one, and I think we should all go through that. So these are divided into 1, 2, and 3 class indications. So device closure in VSD, muscular is a class 2A indication. Percutaneous or perventricular, where we doing the either in the hybrid lab or in the OT under the fluoroscopic guidance. That puncture is done by the surgeon and the device is introduced, because large sizes devices cannot be introduced to the femoral vein. So in the small babies with muscular VSDs, we can do a perventricular device closure also. or otherwise in selective cases like where there are multiple VSDs which cannot be closed, we have to go for a PA band initially at 2 to 3 months and then go for a total correction of this closure after 1 year. Very low birth weight, very low weight babies also, and with comorbidities where cardiopulmonary bypass might be a risk, can also go for a PA band as an initiative. But nowadays we do not prefer PA band, and our ideal aim will be to go for a total closure at the VSD surgical closure only. So device closure is meant for muscular VSDs, the post-operative residual VSDs or the post-infarct myocardial infarct VSDs. Some perimembranous VSDs where there are rim suitability is there also we can close by a device. Otherwise, all other VSDs will be closed by surgery, open heart surgery. And the results are very good with less than 1% mortality. The chance of heart block is also about 1%. The small VSD is also to be followed up. It's not that if the VSD is small, we just let them go and ask them to come after 5 years or 10 years. The small VSD is also to be followed up once in a year if it is a perimembranous or a doubly committed VSD. Only the small muscular VSDs can be followed up maybe once in 5 years or so. And these small VSDs might develop aortic valve prolapse and aortic regurgitation, and some of them will need a surgical closure. So the outlet VSD especially have a more chance of developing aortic valve prolapse, either the right coronary or the non-coronary cusp. Some of the perimembranous VSDs also can develop aortic cusp prolapse, and if the AR is more than trivial, the indication is to go for closure. Other indications of closing a small VSD is the history of infective endocarditis or of endocarditis. So now I come to PDA, the patent ductus arteriosus. So in a patent ductus arteriosus, nowadays we are having premature babies as small as 400-450 grams, and most of them are born with a PDA which is big. And on top of that, they also have other comorbidities and infection, other things are there. So it is a very big challenge in the nursery to treat these preterm babies. So the preterm babies closure is little different, but otherwise if a child comes to you in the OPD and if you have diagnosed a PDA, so all PDAs where the murmur is audible, the continuous murmur is audible, needs to be closed to avoid infective endocarditis in these babies. So nowadays PDAs are mostly closed more than 5 months by a transcatheter, either coil or a device. And in the premature preterm, as I told, we need to give some medications like paracetamol or indomethacin or ibuprofen with 70 to 80% success in the preterm babies. And some of these preterm babies and babies up to 6 months or a very large PDA need to be closed by surgery, if not a device. Nowadays we have come up with a Piccolo device, which is a very beautiful device. We can treating small babies of 2 kg also with the device. So this is what I have already told. PDA, as we know, is the connection between the aorta and the pulmonary artery, so it is outside the heart, but it will affect similar to the VSD. It will cause LV volume overload, it will cause PA pressure, pulmonary hypertension. So even if the PDA is moderate or large, it has to be closed. And small PDAs only, which are silent PDAs, can be left alone. So mode of closure less than 6 months when the baby is very small, maybe surgical ligation will be preferred, but after that the device or coils are preferred. So these are already described. Now we come to the atrioventricular septal defect, where it goes along with the VSD. I will not repeat. If the VSD component is large, we go according to the VSD. If only ASD, we go according to the ASD. But if the ASD is large, the timing is earlier because they also have AV valve problems and regurgitations are there. So the surgery needs to be done around 1 year of age. Obstructive lesions, as Sir Dr. Kapoor already described, severe stenosis, aortic stenosis, or valvular or subvalvular needs to be treated. If it is a valvular stenosis, we can do a balloon dilatation. If it is a subvalvular or associated with other lesions, or a coarctation where the gradient is more than 20, we need to deal with them. So left-sided obstruction, if it is aortic valve, you can do a valvoplasty as we see here. Here you can see the balloon being placed across the aortic valve. The coarctation also being dealt like with balloon dilatation if it is more than 6 months to 1 year. Less than 6 months babies of coarctation are dealt by surgery. So mode of intervention more than 6 months will be balloon dilatation or surgery. If it is a long segment, definitely surgery. Only discrete coarcs can be dealt with balloon dilatation. And older children of more than 10 years or 27 kg, we put a stent along with dilatation. If there is LV dysfunction in a coarctation, then the intervention is immediate, class 1 indication. If there is associated hypertension, the class 1 indication. If the gradient is less than 20, we wait and follow these children as close follow. So with hypertension, with dysfunction, the surgery, timing of intervention is immediate. Pulmonary stenosis. This is again almost similar to aortic stenosis. They can also present in newborn when there is stenosis and there is a PFO shunting right to left, there will be right heart failure. So some of them present to us even in newborn age also. And critical pulmonary stenosis with tricuspid regurg, it is also a challenge to open their pulmonary valve, which is very small. So we do them in the cath lab as early as 1 day old babies, and with pulmonary balloon dilatation, the gradient when is more than 60 or more than 2/3 of the systemic pressures. Absolute gradient is not preferred. More preferred is to take the systemic blood pressure, and you have a more than 2/3 gradient. If they have associated RV dysfunction, hypoxia, it has to be intervened without irrespective of the gradient. Now I come to the cyanotic heart disease. After this pulmonary stenosis, there are the top 5 T's as we remember. TOF, tricuspid atresia, TAPVC, total annular pulmonary venous return, truncus transposition, and the hypoplastic left heart syndrome, and the pulmonary atresia, the DORDs. So in a TOF, which is most common, so we stress on that. Dr. Jyoti will be talking in details. I just tell you about the timing. If the anatomy is adequate, we go closure by 6 months, and if the annulus of the pulmonary artery is small, then we allow a time up to 6 months, and we have to close them after 6 months. So the immediate intervention, and the babies who are suffering from spells, cyanotic spell is very important to identify in the cyanotic babies, and the spells can be dangerous and can cause death, convulsions. So we have to deal with these babies. Saturation is less than 70%, history of spells, hemoglobin is 18 or more, PCV is more than 60. We have to manage these patients as early. If the baby is stable, this minimally cyanosis, ideal age is 1 year. If there is significant cyanosis, as early as possible. If there is VST with pulmonary atresia, the extreme portion of TOF, and then the conduit repair is done after 2 years, but if they are symptomatic earlier and the cyanotic, then we have to do a BT shunt or a stenting of the pulmonary PDA. So these are the treatment options. BT shunt is always there as a palliative for TOF. Nowadays we are also doing balloon dilatation of the RV outflow, or putting a coronary stent in the RV outflow tract, or a PDA stent also. This is one of the pictures showing the balloon dilatation. Other things are less common, but whenever we get them, like transposition can present at newborn, and even obstructive TAPVC can present in the first year, 1 day to 1 year of life. TAPVCs can present. So the operability in a truncus, or a TAPVC, the saturation is more than 85%. There is cardiomegaly and CHF, so they are operable and they should get surgery truncus by around 2 months of age. TAPVC, if it is obstructive, immediate surgery. If it is not obstructive, then around 2 months of age. TGA transposition, when the septum is intact, so they are only surviving because of the PFO, the atrial communication, or a PDA. And so their ideal time of operation is 10 to 14 days, by 4 weeks at least, and arterial switch should be done. So this is the best time for surgery, and the results are best in this time if we can identify them and follow up closely and get the surgery done. You just have to switch over the great vessels, which is a challenging operation for the surgeons, but with the advancement of our science and the techniques, the results are very good, and if it is successful, they lead almost a near normal life compared to the high mortality of more than 95% by 1 year if they are not treated. So Sanings is less common these days because we are identifying them thanks to our pediatricians who refer them to us. Sanings is done at the atrial level, not the arterial level, and done 3 months. Surgical plan, I told arterial switch, then the alternative is a PA band and a Sanings. So by 4 weeks arterial switch operation, and after 4 weeks we have to see about the left ventricle, because what happens after 4 weeks, the left ventricle regresses. Because the left ventricle is supporting the pulmonary artery, gradually it regresses. If once it regresses, the surgeries might not be successful. So in borderline cases, we evaluate them, we do a PA band followed by the arterial switch. But if that is not possible, then the possibilities of a Sanings operation. Cough like other conditions, I will not go into much details. If one thing only we have to know, if it is for a 2 ventricle repair, which means if we can correct them anatomically, then that is the best way to do. And average all cyanotic heart disease total correction is done around 1 year. And if it is not so, if it is going for a single ventricle, we have to deal them earlier, like a PA band or a VT shunt by 2 months of age, and then a Glenn operation at 6 to 8 months, and then a Fontaine operation at 5 years. So these are the step-wise management which we decide after careful echocardiography that their heart conditions are such that they can be anatomically corrected by the surgeon. Then it goes for a total correction, otherwise it goes for a single ventricle. And many of these single ventricle patients ultimately can go for the heart transplant in future. So this is the thing: PA band or VT shunt early by 2 months, Glenn shunt 6 to 8 months, and Fontaine at 4 years. TAPVC I have already described. Obstructive will go emergency, non-obstructive by 2 months. So the take-home message would be a strong degree of suspicion is needed. We have to meticulously examine them front and back to come to a suspicion of our disease and timely referral for a good outcome. There are daunting challenges in our congenital heart patients. We have paucity of information. The babies do not speak. So we have to diagnose them by our careful observations. And there are financial limitations and uncertainty about outcomes which we have overcome, most of them by our advancement of science. Thank you.
Not many pediatric surgeons in India, I would say, so they don't have any competition, but of course they are doing a lot of life-saving work. And I have seen his excellence in pediatrics by sending my own patients. He does a good job, and he's one of the courageous operators. You see, when you take a serious, difficult surgery, then it shows your courage. And the surgeon knows that they have a very high energy level that they are operating themselves. Dr. Shastri and Dr. Pandey will agree. And myself, when I do complex angioplasty also, then also we are having high energy rush because we want the patient to survive and the best result. So I compliment once again Dr. Muthu to do good work for the country and also for many international patients. He has got many plaques I can see when I go to his ICU there. So let us have his talk with Dr. Muthu.
Good afternoon. I'm Dr. Muthu Jyoti. I'm the Senior Consultant Pediatric Cardiac Surgeon at Apollo Hospitals, New Delhi. I've been there for the past 15 years. Now, I thank Dr. Gupta and this organization to invite us to give a talk today. He had asked me to talk generally about pediatric cardiac surgery. I thought it was very difficult to do that in 15 minutes, so I thought let's do it with a common problem. So I thought I'll start with tetralogy of valve, as we know is the commonest congenital heart disease. So when it comes to breakthroughs, there is no major breakthrough in the surgical procedures. You know, the surgical technique, there is nothing much. But rapid progress has happened in the interventional procedures like palliation and the correction of congenital heart diseases as early in life. An increase in the expertise of protocols to evaluate congenital heart diseases even antenatally, post-operative care and long-term follow-up to improve the longevity and quality of life. So that is what has happened in the last few decades. Now, history of management for patients with tetralogy represents almost the entire evolution of management of almost all congenital heart diseases. It's one of the commonest cyanotic heart disease, constituting about 75% of all the cyanotic patients. Now you know the four parts of the tetralogy, which is ventricular septal defect, infundibular pulmonary stenosis. Now these are the two main things. And the infundibular pulmonary stenosis causes right ventricular hypertrophy, and also there is overriding of aorta. Overriding of aorta, what does it override? It overrides the BST. That's what is the tetralogy of Fallot. So it's the same thing now. Now the treatment part, as we used to have palliative shunts. We used to do classical Blaylock toxic shunt as early as 1945, and the first complete correction was done in 1954 using mother as the bypass machine. And since then we have had valve conduits introduced in 1964. The modified Blaylock toxic shunt, where we put a graft between one of the subclavian arteries and one of the pulmonary arteries, was started somewhere in 1982 at Great Ormond Street Hospital, which is where I trained for some time. From the 60s to the 80s, there's been marked improvement in survival of intracardiac repairs. Progressive decrease in the age of primary repair to almost the first few months of life is what is now practiced all over the world with fairly good results. Now, if you left the tetralogy without treatment, what would happen? The 1 year survival is about 66%, the 2 year survival will be about 49%, and the 20 year survival will be only about 10 to 15%. It is because of the physiological problems that we face due to the anatomical problems. There is severe cyanosis, the hemoglobin is very high, platelet counts are abnormal, so these kids are more prone for cerebral strokes, renal failures and multi-organ failures as age progresses related to cyanosis and its complications. Now the investigation part, echocardiography is the primary tool for imaging TOF. Contrast enhanced CT angiography of the chest, more widely accepted in the current era if you want to see the branch pulmonary arteries. Cardiac catheterization has got a role, but it's getting more and more limited because we get all the information that we need by echo and if needed by CT pulmonary angiogram. The only reason I say it's got a limited role is that it gives definitely information, but then cardiac catheterization is such an invasive procedure, and these kids who have got severe cyanosis could go into spells during procedure. So it adds to a little more of morbidity. But still, if you have tetralogy with other complex congenital heart diseases or things that are not very clear, even in a very detailed echo, cardiac catheterization still has got a role. Now, the gold standard for diagnosis is the Z-score. The Z-score of measurement is the number of standard deviations of a value from the mean value at a particular body surface area. In other words, a Z-score of 0 corresponds to measurement equal to the population mean. That should be the normal for an ideal population. Now, the Z-score is measured is primarily for assessing the size of the branch pulmonary arteries. If the size of the branch pulmonary arteries are within the Z-score range of a particular body surface area, however small the child is, irrespective of the age, weight, we could still go ahead in today's world for a complete correction of tetralogy. So the range of Z-score is from -2 to +2. Any value below -2 is considered to be very small hypoplastic pulmonary arteries. In those cases, if you go and did a complete correction of closing the VST or putting a patch in the right ventricular outflow tract, because the pulmonary arteries are small, these kids will develop RV failure. At the same way, if it is more than -4 or -5, they are definitely hypoplastic and they will only need palliative procedures. Now, Z-score of -4 or more indicates unfavorable anatomy, and a Z-score of +3 or higher indicates very dilated aneurysmal branch pulmonary arteries, which we see in absent pulmonary valve syndrome, where there are hugely dilated pulmonary arteries because of the severe PR, and there is possibilities of compression of the bronchi, producing recurrent pneumonias, collapse, and bronchomalacias. So measurement of Z score has made it very easy for easy feasibility of complete intracardiac repairs versus palliative procedures. The CT angio is less invasive. It's an excellent assessment tool on the basis of the superior imaging of the RV outflow tract, sites of the pulmonary arteries, collaterals, and coronary abnormalities. And the newer software have got the ability to reconstruct the entire image in 3D. So you can see the pulmonary arteries from the front, from the back, from the top, in whatever way you want to. It can be sliced and gives a better appreciation of the anatomy that you're going to face in theatre. Now this is a CT angio, and this shows the branch pulmonary arteries very clearly that you can see there. And now this is again a CT pulmonary angiogram which shows the MPA and the branch pulmonary arteries. Now cardiac catheterization is more invasive, precipitates cyanotic spells. It's not murder in a simple, straightforward tetralogy of Fallot. If you only have RV dysfunction or LV dysfunction and you want to know the end diastolic pressures and all that, that is where a cardiac cath will be helpful. Just to delineate the anatomy, I think echo is the number one modality, and the number two is, if possible, a CT pulmonary angiogram. Now, chest X-ray, we all know, the typical boot-shaped heart that we see in all tetralogies. Now, the timing of operation. Now, there used to be an older concept that kids should be 1 year of age and 10 kilograms. It's some kind of a magic number. 10 kilograms and 10 months or 1 year of age. It is no more like that. From there, we have come down to say 3 to 6 months of age and even 6 kilograms. Now, but having said that, the lowest weight that we have done in our hospital is around 4 kilograms. That is the present concept. The idea is that we don't want the children to be exposed to cyanosis or hypoxia for an extended period of time. It is not good for the brain, it's not good for the entire development of the child. So we do it as soon as possible, provided the anatomy is feasible. As I said, if the Z score is within the normal range, we still go ahead, because age or weight does not matter in today's world for any pediatric cardiac surgical procedure. It can be done safely. Now, the only thing is, in a private setup, if you did a tetralogy of Fallot in the first month of life or the second month of life, it is just that they will probably stay in the ICU for a longer period of time. And as we are all very cost effective and very, very conscious about the finances, so only because of that, we may be restricted in doing tetralogies in newborns, the first 2-3 months of life. But generally, by third month of life, majority of the centers in the world are doing complete corrections of tetralogies, provided their anatomy is feasible. Now, currently, the trend is to perform surgical procedures before the age of 1 year and preferably by the age of 2 years. Majority of patients born with tetralogy now thrive very well into adult years. Now, the contraindications for a primary repair is when you have very low birth weight, recurrent cyanotic spells, very small pulmonary arteries, associated problems like multiple VSDs, or these are the reasons where we cannot do a complete correction. There we do a palliative shunt, which is connecting one of the systemic artery to the pulmonary artery, one of the branches of the subclavian artery to the pulmonary artery. So the initial was, the classical BT shunt, where we used to tie off the subclavian artery and directly connect it to the pulmonary artery. But nowadays, what you see on the left side is you interpose a graft so that the blood supply to the limb is also not compromised. Because when you do a classical BT shunt, the incidence of limb ischemia on that particular side is very high. And if you are a right-handed person and kids have claudication while writing and all that, so that is why this concept of using a graft has come into existence. We use a PTFE graft, polytetrafluoroethylene graft. The only thing is that these grafts tend to get blocked, so they need to be kept open by giving aspirin at the dose of, say, around 5 milligrams per kg body weight. And that should be continued till the next operation. Now, so apart from this, in the modified BT shunt, we also try to avoid dehydration, excessive sweating, fever, vomiting, diarrhea. All these need to be sorted out and treated as quickly as possible. Because once the child gets used to a little higher oxygen concentration, if the shunt gets blocked, they don't like it. The body does not accept it. They don't accept the levels that they had before surgery. So they decompensate, and we've had many times that kids even die before they could reach reach the hospital if they have a blocked shunt following an episode of acute gastroenteritis. Now, primary repair, the advantages is it avoids the risk of palliation, prevention of, whatever you do on the shunt, it causes some kind of a distortion in the pulmonary artery. So all that can be avoided. Avoid the need to do another operation and prevent unnecessary RV dysfunction. These are all the reasons why we want to do, and more importantly, to prevent unnecessary exposure to hypoxia for extended periods of time. So the complete correction is basically closing the VSD and relieving the pulmonary infundibular stenosis. By closing the VSD, the overriding gets corrected by itself, and the right ventricular hypertrophy will regress with time as soon as you release the pulmonary stenosis. We always, another present thing is that we always leave a small patent foramen ovale in all tetralogies. This helps in the immediate, this is a newer thing, it helps in the immediate postoperative period, where if there is RV dysfunction because of muscle resection, this PFO will act as a vent and decompress it to the left side. So the offset is that the saturation may be a little less, maybe low 80s, high 80s or low 90s, but still the post-operative period is very small. And most of the times, the PFO doesn't need to be done anything, but if at all it causes too much left to right shunt later, the cardiologist can always plug into the device. So post-operative complications, what we normally see is RV dysfunction, RV failure, but that is all overcome because we know how much to excise and always leave a PFO, and we don't put big patches across the RV OT because it causes very severe pulmonary regurgitation. Apart from that, infection, bleeding, and heart blocks, which are common to every surgery. Late problems are because of severe pulmonary valve regurgitation, which can cause RV failure. So there are some indications where we have to go and put in a valve, but even there, the recent advances is that we can put in a percutaneous valve or percutaneous pulmonary valve in the right ventricular outflow tract, and that can take off all the stress related to reoperation. So this is the last one I just wanted to say. Tetralogy is such a disease that you correct and give oxygen to the body. They do remarkably well. Now this child, which is in the picture, is a 7-year-old boy who came from Nigeria. He came all the way from Nigeria and he came to the Apollo emergency, and he arrested. So we brought him up, resuscitated him, and I thought because he arrested, maybe we could do just a BT shunt and improve his oxygenation and get him better. So we took him for a Blaylock crossing shunt. We did a right-sided shunt. But I think the amount of oxygenation which improved after the shunt was not enough for the body. So we brought him back to the ICU, and again he arrested. So I can tell you this child was massaged for nearly one hour when we got the theatre ready. We took him back. So, the shunt was working, but still the child is arresting, so we didn't know what to do. So we thought at least we'll put the child on the heart-lung machine and give some support to the body, give better oxygenation and rest to the heart. So we put him on bypass, and then we redid an echo, or we saw the heart from outside directly, because the shunt is done from the thoracotomy, but this was from the sternotomy. The anatomy looked more or less okay. So we took down the shunt and I closed the VSD and did a complete correction of tetralogy of Fallot. This boy was not waking up for 3 or 4 days, but then by the 5th postoperative day he woke up. Another thing is he also came with the left side hemiplegia. So almost the left side hemiplegia also recovered partially, and he woke up. There was no other major problems related to the brain, and he went home very happily. And now I'm told that it is now 10 years since I had the surgery. He's able to walk, his speech is okay. So what I'm trying to say is tetralogy of Fallot, timely correction is a very rewarding operation, and we see patients living into adult life with a near normal adult life. Thank you very much for your attention.
Justice has been done to the talk, so there is no question. I just wanted to know myself, when you operated on tetralogy, do you expect a full lifespan, complete lifespan for the patient?
Growing up into a good adult life. Now, the most important thing is the longevity depends upon the follow-up. See, it doesn't end with surgery. So they need to be with the cardiology follow-up for extended periods of time, because post-operatively they could develop arrhythmias, they could develop pulmonary valve regurgitation, RV dilatation, arrhythmias. Sudden deaths are very common with arrhythmias. So the quality of life and the longevity of life depends on how compliant a patient and their family are in terms of follow-up. If they are on good follow-up, we have seen patients live up to 50 years, 60 years of age, have had kids who are normal kids, have had kids who have got tetralogy of Fallot also. If it is a girl with a tetralogy, the chances of that girl producing a tetralogy is a little higher than a male who has got a tetralogy of Fallot. So we've seen the entire thing. We have seen kids with tetralogy, having tetralogy with tetralogy, normal kids. So it is not it can't be answered just like that. Longevity, everything depends upon the follow-up.
We are doing in conclusions justify. I think you're the first talk in the our conference. Missed you. You will tell more about yourself. He is a dean in Ashoka University. It is what they are dealing. And before that, you were in CSIR. So just
Went into genomics until recently was the director of the CSR Institute of Genomics and Integrative Biology. You may have heard of us during the time of SARS-CoV-2 sequencing. Recently, I shifted to the Ashoka University. That's a picture of where my office is. To start a new school of biosciences called the Trivedi School of Biosciences. Today I'll speak to you all regarding emerging trends in how technology is changing the future of health. I'll confine myself due to time to artificial intelligence. One very important thing to talk about is when many of us speak of digital health, we think of it as a digital way using IT of delivering health in the old way. While that's a temporary thing, you can do telemedicine, telecardiology, tele-everything. But the real transformation, the real digital health, includes a fundamental digital way of looking at things, including their genomes. Today you can measure, read, write. I don't know how many people in the room today know you can create genome using synthetic nucleotides in new bacteria. It's already possible to edit the genome. Today people with sickle cell disease are actually being treated for sickle cell disease. There are trials going on in monkeys whereby mutating a normal PCSK6 gene, you are able to lower cholesterol for years and lower cardiovascular risk. Just one hepatic change in one gene, creating a mutation in a normal gene. That's where we are. But speaking today and confining ourselves more towards AI, the biggest fundamental of digital health is the better life. Technology for the sake of technology will take us into directions we may not want to go. And the goal must be stated, which is to improve access, quality, affordability, but also to some degree equity and justice. And this comes in particularly for genetic engineering, where it is possible to create things that might be heritable to future generations, but do we really want to go there? One very important thing about AI that I think is not stated enough. AI, big data, machine learning are all the same thing. At this moment, there is nothing called artificial intelligence that is not simple machine learning. It comes in 4 flavors. Flavor 1, the most common, is of supervised learning. In supervised learning, a human being decides the classification. It feeds the data to the machine. The machine on its own learns a set of rules that allows it to classify as well as the human. It cannot exceed human classification because by definition we are classifying things. So even if the definition of disease X is a bad definition, the machine will learn to classify just like a human. Unsupervised learning recognizes the fact that we ourselves do not know how to classify disease. If you went to the 1950s and looked at what COPD used to be, you will find that post-tubercular bronchitis and standard bronchitis are all part of COPD. Even asthma was part of COPD. And the reason clinicians in 1950 thought of asthma as part of COPD is life expectancy was low, treatments were the same. What difference did it make? You're going to give them some kind of inhaled atropine derivative anyway. So recognizing that clinicians themselves do not know how to classify disease, unsupervised learning starts the data and looks at classes within, some of which may not be recognized by clinical practice. Semi-supervised builds the tool And reinforcement learning, you will see increasingly in ICUs, is where decisions need to be made. So situation A needs a decision, situation B needs a decision. So BP management, fluid management. Again, very nice work coming out of UK, showing that machines can do it quite well. So where is the data going to come from? A, the data will come from big biomedicine practices, and the other is from us. In the first one, you are seeing massive data sets being created. The UK biobank, tissues are being decomposed to single cells, genomics, every kind of omics is being run. And this is trying to understand health from the bottom up. Start with the genome, work upwards. The other type of data, which is far more relevant to the room today, is our data. Every time you go to a hospital, every time you get a procedure done, every time you get a test done, data is being generated. Capturing and using this data in an ethical way will be fundamental to the progress of AI. And India is trying to come out with an appropriate digital health data policy. There are challenges in either direction. If you say anybody can use the data, privacy is lost. If you say explicit consent is required, all the data we have accumulated over a decade is not usable. Finding that balance in a way that protects the interest of the patient while advancing the field is key, and we must keep an eye on that. You know, there are digital twins. If somebody in the room has bought a Porsche recently, the entire suspension of your Porsche has a digital twin. You can actually log on to see what is happening when it requires service. If you fly in jets, jet engines have digital twins. If the jet flew through a sandstorm, it knows it. It knows servicing will now have to be advanced. So GE does that for jet engines. Similarly, cardiologists, given the organ of interest, is somewhat an electromechanical one. Most electrical things can be mapped, most mechanical things can be mapped with sufficient number of sensors. And many of you implant things that contain sensors. So in arrhythmia management, it is possible in certain areas to almost simulate what will happen. If you want to create an ablation on a particular part, what will happen? So you can run algorithms, and this is done again only in Germany, in a few places right now. But you can simulate what will happen in the arrhythmia intervention, and you can lead to complications in silico. Something happens to the patient, you can come back and plan the procedure. Not too many other organs have this capability, so cardiologists are at the forefront. In any case, it's not possible always to get the data from the patient in which you want to do the intervention. That can happen only in a few patients, where you implant electrodes and all that. Neurology is the other place this is happening. So what you want to do is learn from multiple patients with multiple types of data, create the models which you apply to an individual patient, and that's the tough part. This is where we are still thinking, but cardiology is a pretty active field. It's not just about images. In many other fields, images are the essence, radiology, and AI is very good with images. But cardiology is a bit more than that, so it's going to be tough. Looking at the biggest success of AI, the game of Jeopardy, where computers were asked to answer questions just like human participants. A typical question could be, this is the hat, my dear Watson. And this is the name of the hat, my dear Watson. We would know it's Sherlock Holmes. We would know it's D.S. Locker, but the biggest challenge in AI was to figure out what question was being asked. Answering was easy. Given all the information you have for every possible question, if you can figure out the question correctly, from the way humans say it in a complicated way, you can find the answer. So IBM won this competition, beat the two highest ever winning people on this game of Jeopardy, and immediately started IBM Watson for oncology. With big promises regarding changing cancer, we all know what happened, nothing much. And the reason is that in the game of Jeopardy, there are clear answers for all questions. Jeopardy answers only require existing data. But in real medicine, in biomedicine, there may not be any right answers, there may be many right answers, and the entire data could be wrong in terms of answering the question that you're trying to answer. So yes, AI is not yet ready, anywhere near ready, to replace the judgment of a human doctor in their practices and complex things, but for simple things, it is doing well. I'm going to give you an example. In America, where people have insurance, they say that the insurance company is more vested in your health than anybody else. So they use an algorithm trying to figure out which patient will become sicker, get admitted and consume health care. And this algorithm is used to give them extra outpatient care. In analysis that you see here on the left, the dark line are black people and the yellow line is white people. On the x-axis you have the risk score, on the y-axis is how many conditions they have. You can see to get the same score from the algorithm, a black person had to have more medical problems. Why is that? Does AI care about skin color? Is AI biased? No. The very simple reason is, how do you know somebody is sicker? You know somebody is sicker when the time they come to seek health care. If a person waits to get sicker because they are poor to access health care, then AI will simply adjust for it. So AI is fundamentally stupid. It does not know human nature. Imagine an algorithm like this working in India. A poor person would have to be very, very, very sick to get a score requiring hospitalization from their current behavior. So we need to learn about these things. We cannot leave it to people who don't know medicine. And engagement of doctors in this area is going to be very important going forward. And that's the last message I'd like to end with. You have to know something before you can translate it for others. And knowledge precedes translation. Thank you.
It's my alma mater. In foreign countries, being diabetic, as he said, it's very important. We are talking about cardiology, we are talking about stenting and all these things. But one should understand, in foreign countries, the amputation rate is of lower limit 2%, while in India it's 8 to 10%. Sometimes it goes to 15%. What is more important, because I will briefly said, I have brought the slide because there are people from side other than medical. Okay, so it's a motor neuropathy, that is most important thing. It is paralysis of lumbrical muscles, toe become claw-shaped, and bones of feet, tips of toes and joints become under pressure. So that's gives a pressure. This is the anatomical changes in the foot of a diabetic. Where is the indicator? Can you see this? I will take little time. See, you see it has become a claw shaped. And this is a pressure point because of lumbrical paralysis. It has become. This is the pressure areas. You know this, and other one is this is the area where the blood supply is also compromised. So this is the anatomical changes in the foot of a diabetic. Always remember this photograph. Okay. See, this is what happens to these pressure areas. See, ulcers, gangrene, they develop in the pressure areas. This is the heel. Okay, this is the heel of a patient. This is also again one of the pressure areas. See, these are my patients who are coming to me. See, this is the pressure areas. Okay, this is because of the tight shoes on the malleolus. It has become an ulcer. So this patient was a businessman, very rich person, developed this ulcer. How it happens? He took some Ayurvedic medicine or something, and then it turned out to be this. Okay? And when he came to us, then see, this was the scene. I removed all the debridement, the foot, sole of the foot looked like this. I advised for amputation, but since they had a lot of money, they wanted that this should be preserved. So it took full 5 months to do this. Okay? So point is that you should take care. Prevention is better than cure, rather than undergoing such things and then correct it. Second is neuropathy. What they talk about sensory neuropathy. pain and tingling sensation in multiple areas of the foot skin, and decreased sensitivity to cold and heat. And if you put a sharp or pin also, they will feel very less pain. So we just touch the hot water and burn it out. So it is advised, there is a hot water while you are taking bath. If you want to feel the temperature, don't put your foot inside the water. Put your elbow joint in the water so that you can feel it whether it is too hot. Otherwise, foot will burn. Okay. Then autonomic neuropathy. Disturbance in the functioning of sweat glands and glands responsible for keeping skin moist. Come, Dr. Shastri, come. So what happens, because when skin gets dry, sebum is less, sweat glands are not working properly, then it develops cracks, and cracks leads to infection. And what happens, AV shunt, they open up, and what happens that blood supply is also, it looks red, foot will look red, but less is blood supply, arterial supply is very less. So how can you recognize? You lift the foot, it becomes pale. Once it's down, it will become red. So don't confuse with that. So what, because we susceptible to this trauma, infection, and developing of gangrene, ulcer, there is no time left. Very rapidly it will develop in the diabetes. And if you know that a diabetes person, how will you know that infection is there? Because there will be this thing, very bad smelling socks. So he can understand that. So, and another thing, diabetic patients, they are old patients, they sit for long hours. So that leads to venous congestion in the feet. And because since decreased neuroinflammatory response in diabetics, so they develop this kind of cellulitis. It is very, very common. You will find your relatives, they are having this kind of feet, and this is because sometimes you have to take incision, longitudinal incision, to take out the pus. And see that this is the X-ray. See how we say that calcification is there in the arteries, fat deposition. See, well calcified artery. Okay, you see on X-ray. See, this is a forearm, because radial artery is calcified. Now, after this, it starts depositing like this, narrowing starts. See, the total block, femoral segment. See, this is the picture in the infrapopliteal region. See how narrowing, blocking, and all this. This is the typical picture of a diabetic person. And sometimes diabetic persons come with the backache. We think that there is some vertebral problem, or this is a aortoiliac junction narrowing. This leads to buttock claudication. Sometimes backache, they confuse it with the backache. See, diabetics, they keep on smoking, and see, this fellow was a colonel in army. First he lost this feet, he continued to smoke, then he lost this. It was done amputation in Chandigarh, and then it was done by me. See, these are the all patients who are coming to our OPD. This is a foot of an income tax commissioner, lady commissioner, and see how she was neglecting it. So this is the narrowing. If you do the angiogram, you will find narrowing, and then we treat this either by endovascular treatment. You can see we can to increase the flow. That is very important. See. Then role of bypass surgery in diabetic foot is very important. So we do dorsalis pedis arterial bypass, posterior tibial arterial bypass, important in ulcer and on heels, femoropopliteal arterial bypass. See this I have used the vein, posterior tibial artery joined to the popliteal artery. See that good flow. Okay. So this is to preserve the prevent the foot undergoing amputation. So these are the various bypass grafts, they are available to do this. See this femoropopliteal or junction. See this fellow had this some problem, kidney problems, so many problems. So we stenting was not it was discussed. So we did the femoral popliteal bypass and femoral bypass and then femoropopliteal bypass. It's still working after 1 year. You see this. So these are the, as I advise, that the pressure ulcers. So we do the back dressing and take at least 3-4 months to make it heal. Very regular watch, follow up and all this, person get healing. Pneumatic foot walker we use, and these are the special shoes for diabetes. So to prevent to protect it from attack of neuropathy, attack of vascularity, and some important tips for saving lives. Always advise daily morning walk, tobacco abstinence, smoking, no alcohol, of course red wine sometimes, avoid being overweight, and the most important thing, never walk barefooted, use soft shoes and cotton socks, keep your feet clean and dry, that is very important, because after bath, within the toe, take a towel, clean it, and then apply, take some surgical spirit and rub it, so that toe spaces they remain clean. Otherwise, that is a very source of infection. Do not ignore blisters, cracks, and cuts and feet. Consult immediately a vascular surgeon. Avoid prolonged sitting for more than 1 hour. After 1 hour, get up and walk for 10 minutes, and then sit again. Venous congestion in a limb of a diabetic will lead to cellulitis. That I think most of the physicians, they don't understand why this is redness, sudden redness. Arteries are working well, but why sudden redness? Because of venous congestion leading to cracks are there in infection, and then cellulitis, and then pus formation also. Do ankle exercise every hour for 5 minutes. So always advise this. So what you call चरतो चरता भगा, यानी जो चलता उसी के साथ भाग जो संपदा भी चलती है. This is our Sanskrit saying. So प्रतिदिन 7 to 8 kilometers you should walk, try to, and because it increases the blood flow, and that is the basis for saving the feet in diabetics. We are a poor nation and cannot afford huge spending on treatment of a foot ulcer and leg. Infection in diabetes which are preventable. A person with non-healing leg ulcer loses earning and self-esteem as well. Do not inflict more injury to an already traumatized person, and give him a proper advice at a proper time. That will be a great service to our society and nation. Thank you.